Hi.
Okay, actually, we have I have 4:32 or 3. And we now have a quorum, so I'm gonna call the November 21st, 2024 meeting of the Monroe County Board of Health to order. Linnea, did you say we do have the minutes from the last meeting in September?
We do not have the minutes from September 19th. We have October minutes, however, and there was one.
We had a meeting.
No, we canceled.
It was very brief. It was very brief. It was like
Oh.
2 minutes, remember?
Oh, to approve the special
That
health.
meeting.
Okay, yeah, okay.
And I said,
Okay.
what happened in
Yeah.
September? It just happened to be finished. I got it.
I'm so small. This is good. All right, so we had a very brief meeting, which I was out of town and
And Aurora wasn't here either.
well, maybe you were also
I
out.
was out of my mind. So Sarah very competently filled in.
Okay, so has everyone had a chance to read the 3 lines about the last meeting and minutes? And if you have, then would somebody please make a motion to approve the
I move
minutes?
to approve the October minutes.
We went here, right?
Can't I still move to approve them?
Yeah,
I guess you can, but all right.
Oh, there's Kay. Hi.
I'll second.
How could you speak to the accuracy of it?
Well, she didn't. She simply like asked
can
to approve them.
I'm just gonna approve. I'm also gonna vote on them.
Okay.
I wasn't here, right?
Yes. It's been moved and moved. Has it been seconded?
Yes, I second.
Seconded. Okay. Moved and seconded to accept the minutes. All those in favor, please say aye.
Aye.
Opposed? Thank you. Let's move on to public comments. Do we have anyone? No one here, but is there anyone online? Okay, seeing no one obviously present for public comments, let's move on. Under department updates, but this isn't exactly a department update, but Dr. Lee McKinley is with us tonight. You saw some of the materials that we had sent out previously. Hope everyone had a chance to look at both of those. I did when we got it and reread them today. So looking forward to your presentation, Dr. McKinley.
Thank you. I can get it up here. PowerPoint, that's like it up there. So I was, I guess I'm up, this is a public comment.
Well, go ahead.
I'm not official anything really, but, I was born in Bloomington. I've lived here most of my life. I know several people here. I know Kay and I were at Ivy Tech, we got to teaching some. You know, you came to our summit. I sit on the MCEC committee, which is a Monroe County Health Equity Council, which is part of CJM. And so I've been involved in doing in some of the committees for the CHNA, Community Health Needs Assessment, and also the CHIP approach, the CHIP planning. I've done that the last couple of years since I've been semi-retired. So what I want to do is to present you kind of some data about, that's it, about where we are from my standpoint. Maybe it'll look different from your standpoint because you're actually, you know, on board. I'm a consumer of health. And so, okay, I'll let you do that. So I want you to pretend that you're not a board member, that you're just a consumer and that you went into Kroger today and your blood pressure is 220 over 110 and you feel just fine. What do you do? And so I've had lots of patients and doctors kind of come call me and I interview with you about how things work in our community as far as getting getting care if you need it. Because it is a challenge. I went to my own office, just after I retired, and I was on Medicare, and I walked up to the reception desk, and my picture is actually hanging on the wall behind her still. And I said, I need an appointment. I'm 65 and I need my medicines refilled. And she said, well, we'll be happy to see you. We'll put you down as a new patient since you haven't been here in 3 years. So we'll see you in April 2025. I said, well, I'm fine, feel fine, but my medicines are going to run out by then. She said, we can't have medicine until you see the doctor. I go, yeah, I know that. She said, I think you should go to the emergency room. I said, well, I don't think that's where you go for refills. She said, unless you're having symptoms. I said, but if I'm taking my blood pressure pill, I could have a stroke and then I will have symptoms. And she says, should I call 911? I go, no, I'm not having any symptoms. I'm just kind of teasing you a little. So I had to actually, I didn't want to pull any strings because I'm a doctor, but I did. I had to pull strings with another doctor to get refills until I could be seen. And so I guess I could have gone to some other clinic, but I wanted to be where my records were at IU Health. So anyway, that's just kind of an example. And I was thinking back to the COVID crisis. I looked at your website and you had about 1,000 hits per month, I guess, looking at your minutes back during the COVID. And now it's about 50. You know, who looks at minutes, but people were looking. 1,000 people a month were looking at them back in the COVID. So, you know, COVID changed a lot of things. We learned about telehealth, and we learned about Zoom and how to do things on Zoom. We learned a lot of things. We communicated with each other. People's jobs changed during COVID, as you all remember what that was like. And we learned some lessons about how to communicate. And then, you know, what's happened since then has been kind of gone back to the way it was, which is very typical. You know, when the emergency's over, people just kind of relax. And so I was going to talk today a little bit about social determinants of health. You guys know a lot about that because you're in the middle of actually working on homelessness and all the things that contribute to health. And if you look at it, you know, there's people in our community who, when I interviewed them, told me that I was woke, and that I was I a socialist or something, and, you know, trying to cure all these community problems. And, you know, maybe I am a little bit woke, but the truth is 70% of our resources are being used for things that have nothing to do with seeing a doctor. Have to do with getting to the doctor, getting an appointment like I had trouble doing, paying for the pills, all that other crap that, you know, that has nothing to do with your own behaviors. Most people believe that people's problems are due to they eat too much, they drink too much, they smoke too much, and that's true. They're bad, but they only represent 30% of what we're spending. So even if you don't agree with, you know, the woke mentality about trying to help people, it's cheaper to take care of it than it is to not take care of it. And the hospital, for instance, doesn't get reimbursed very much if a guy gets readmitted. And usually the cause of readmission has nothing to do with why they were in the hospital. It has to do with they didn't get their medicines, they didn't have a follow-up appointment, all that stuff, you know, that's in between. So our hospital actually needs our help. I mean, this committee and this board, by fixing those kinds of things, reduces the risk for readmission to the hospital, which is good for patients. Also helps the hospital. So I think, you know, it's a win-win kind of a thing if we can help the hospital do that. The hospital right now on the major diagnoses, psychosis, normal delivery, stroke, lots of things. The only thing that makes money is hip surgery, really. But most patients, they lose 13% of what they spend, you know, on. So they admit a patient, every Medicare admission costs them $1,300 basically. So they can't really make it financially on that. Here's our health disparity map. You've seen Indiana's at the bottom there. We're the lowest. We have the most disparities. IU Health Bloomington. Their vision is to make Indiana one of the healthiest states in the U.S. We're not right now, but we're trying to get there. It has invested a lot of money in our community. I looked and saw that IU Health in Indianapolis has a collaborative called iHeart, where they work with multiple entities under a contractual basis to improve health equity, access, outreach, and treatment. IU, when they built their new hospital up there, found out that they were displacing a bunch of people who lived in poor housing. and they bought up their houses and moved them out. And they realized that people living in that area code, it's only 1,500 acres, had a 20% higher death rate, obviously, than other people in the community. So they are investing in building an infrastructure outside of IU Health that supports social determinants of health, housing, education, all that other stuff. And they have a funding source, you probably are aware of it, it's called CII. It's a big funding source, but it requires, you can't give the money to a board like this. They can only give the money to a group that's convened by a board. So if you had several other groups like the hospital, us, and 3 or 4 other groups all together and form a coalition, you could be funded by that CII, and that comes directly from the IU Health Foundation. The State Department of Health, you guys know a lot more about that than I do. It's interesting, the diversion status of our hospital, which was an issue during COVID, is still an issue. We still are diverting patient ambulances away from our hospital here because they don't have any beds. My own wife was in there about a month ago for chest pain. She spent 4 days in the ER. That was not during COVID, just, normal day. She was 4 days in the ED in the psych bed. That's the only bed they had, and the ER was a psych bed. So she was there. That was she was not a happy person when I took her. But anyway, she didn't have a heart attack, so I should be thankful. Monroe Hospital and Meadows, I invited them both to attend the recent Access Summit, but they were not interested in coming. They don't do CHNA or CHIP because they're not required by the IRS because they're not, they're for profit. And we don't know much about their stability as far as City of Bloomington, I talked to several people. I got some interesting quotes. Health is a county thing. Don't bother us with it. City doesn't want to get involved in healthcare. It's a county thing. And also somebody who sits on the commissioners on the board told me that your budget usually comes in at the very last minute and that they just pass it. They don't really discuss it very much. I don't know if that's true or not, or whether there is debate about what you guys request.
I'm sorry, are you talking about county
County
commissioner as opposed to county council that actually
Oh.
provides the funding?
So you have me there. I don't know. So
Commissioners make policy, council has money.
Unless it has the purse string.
I
So
understand.
it'd be interesting to know.
Don't know which one,
What
but
you-
perception was that they got the budget very late in their cycle, whatever their cycle is, and that they just tended
That sounds like council.
to approve it rather than discuss it, because they just didn't have a lot to say about it.
Really? Because it sounds like council has been wants to cut our budget because
Well, I mentioned that in here. Basically, they want to cut our budget because we're getting money
money from the
from the
state.
state, but that's only for the next 2 years, right?
And
Yeah.
it's not allowable by the legislation.
Yes. Yes, I'm with you completely. There is a thing called Helping Bloomington Monroe, which is a user-friendly electronic platform. It used to be called Aunt Bertha, now it's called Find Help. I think you guys have supported that here. It's been supported. But again, I asked them about whether or not they had outreach to the county area, and they said, no, we're only going to put up kiosks in the city. So, but it's being funded apparently by several people. I don't think the county pays for it. It's about $5,000 a year. But it's very helpful for people who are doing navigation, like social workers and people, case managers, because they can anonymously research what low cost or free care would be for somebody without giving them their name, their phone number, and all that stuff. So it's an anonymous system, which is very helpful. And I think it's something we should support for the county.
Dr. McKinley, let me
Yeah.
interrupt for a second.
Oh, yeah.
Linnea,
Yes.
can we minimize that thing in the right place there?
Well, let's see, can you actually see?
And again,
Is there a water?
Of course I am.
here's that quote: "Budget is presented late the budget cycle and is usually approved as is." I've got
You're so
that.
sweet. Thank you.
But I told the people that I interviewed I wouldn't tell who they were because they're politicians.
But it has to be council.
Probably is. There was talk about reducing the healthcare budget due to the new support from the legislature, but of course, they're only budgeting us for 2 years, and so if they drop the ball at 2025, then you're stuck with funding it some other way.
And that money is not to substitute funding from the county
Right. Just be added on.
in addition.
Absolutely. But still, you know, they're looking at, ways,
But they're gonna try.
they're gonna try. Health data, again, I assume we get most of ours at this level from the state health department. But I looked at several other counties in Indiana that are near here, and they have other sources that are independent, and they make independent decisions, independent of the state. Decisions sometimes. There's the IHIE, which is a health informatics clearinghouse, is now being contacted by counties in Indiana who want to directly get their own data, so they can make their own decisions about what they're going to do rather than data that's been chosen for them to look at. There's something called the Polis Center I don't know much about, Health by Design, and something called Chime. And these are databases that can tell you on a very precise, granular level where people are having difficulties with social determinants of health, basically. And so I'm not sure if you guys have access to those, but several counties in Indiana are starting to get their own data stream, so they can make decisions that aren't dependent on politics. Indiana Hospital Association, I was very disappointed with these people. I called them and tried to get information. They gave me 2 websites. Both of them are non-functional. They don't work. They were supposed to make it, patients could see what their bill is going to be before they get the bill, improve transparency of billing according to the federal law. And those websites are not functioning. Yeah, they might function if I was a member of the Indiana Hospital Association, but they wouldn't function for me, and they're an assist for the public. But not very helpful. The Health Foundation here, Bloomington Health Foundation, I work with them some on access again, behavioral health and equity. They do collaboratively work with the IU Health Foundation, the city of Bloomington. They didn't mention any cooperation directly with you guys. I don't know, do you work with the Health Foundation at all?
Here in-
You were at our summit recently, so that's good. And yeah, they sponsored the summit, and Lori was there, and Dr. Britton was there. Several people were there to talk about access issues. There's the IU Health Foundation. Again, it is allowed to give money out. You've got the Stride Coalition, I think, that's receiving some funding here. But their goal is to build more social capital and self-sustain and reduce the burden of issues, including racial disparities. And so far, IU Health Foundation has had 7 grantees, and I think in our region anyway, I think 2 or 3 in Bloomington. One of them is Stride. This is a question I asked my medical students. There was a 42-year-old guy that came in and he was a no-show repeatedly. And so I asked them what their response would be. Here are the 4 responses I got from medical students and residents. Keeping his appointment is his choice. I have no responsibility to reach out and reschedule. It's his problem. Number 2, completely opposite. I'm his physician, even when he is not in my office, and I will call and make sure he's okay. Make sure he's not dead or has had a stroke or laying on the floor or something. He has wasted my time and another patient could have been helped. I hear that a lot. He should be fired and is free to see a different physician of his choice. So lots of different, these are young physicians.
3 of
in
them are
training.
very similar, actually.
Yes, yes.
Are you aware of IU Health's policy? 3 strikes, you're out.
Really?
Can't see anybody in that office.
Even if they're the only provider in town.
Doesn't matter.
And so there's obviously a tension. As you know, most physicians now are employed. And I started my career being on my own. Lisa knows about that. We were partners. But there's a tension, because you're being asked sometimes to do things that aren't good for the patient, but they're good for the system or the hospital. And obviously there's an ethical problem there. You have to take the patient's side. If you're a physician, you've sworn to do that. But yet we're seeing some bending of those ethics, in large institutions like IU Health. And so it's just something to be aware of. I was very surprised these young physicians did not have much empathy.
Lee?
Yeah.
What level of training were those 4?
These were 4th-year medical students
Fourth
and
year, okay.
first-year residents, internal
Okay,
medicine. This
okay,
is down in
that's what I
Vincent.
All right.
Yeah.
I just
Yeah.
want to know where they were.
We know that
because
in medical
when they
school,
first enter, I'll bet they gave you a completely different
Absolutely.
answer.
we know empathy drops during medical school.
Oh,
It's the
yeah.
highest your first year, right? And it's the lowest when you graduate, which
And
is,
by the time you finish your fellowship, you don't
Yeah.
even know patients.
kind of, fast backwards. Access to care, obviously, that's why I'm here today, is because there's a lot of skewing. They say that 42% of graduating medical students are going into primary care. But if you really look at it, the ones who are going into internal medicine, only 8% of them are going into primary care. 92% of them are hospitalists or specialists. And so the data are very misleading. And basically internists are disappearing in the outpatient world. They're not going to be there. It's going to be nurse practitioners, family physicians, and most internists are going to be specialists, so they're going to be in the hospital. They all prefer shift work. They want big bucks. They want to make 300,000 or 400,000 their first year because they've got big loans to pay back, which I don't blame them for that. But they certainly have a different mindset as far as what they see themselves as. Even though I beat them up for 3 years as residents to think like an outpatient doctor, like I really couldn't get them to do that. It's like, if this was an inpatient, I would just order a CT scan and it would be done. In the outpatient world, we have to fight for those things. In the inpatient world, we just write the order. And so it turns out Indiana is the #1 exporter of primary care physicians. Most of our physicians go other places because we have such a large medical school. So again, you all know what access to healthcare is. And I emphasize usual source of care because most patients don't have a trusting relationship with somebody that they can call and get refills, before their next appointment. They have to kind of fight their way through the system. And the minority now of patients have a usual source of care. They just see who's ever available, urgent care, ER, wherever they can get seen. All of our CHNA surveys since 2015 in this county have shown access to care as being #1 or #2. There's an ecosystem that is required to be aligned in order for all these things that we're doing to work. We don't have a good ecosystem in Monroe County. We have city and county are kind of separate entities. They don't really work together in some areas. You probably know all that. Operating agreements. This is what is happening, and this is what I think we should consider is forming an LLC or some sort of a organization that is an umbrella over all these organizations, and everybody can join the colloquium. You have to buy their way in or whatever. They share some data. IU Health does not like to share data, internal data at all, even if it's stuff that you need to know about. But if we had some sort of a what do you call those agreements between?
MOU?
Hmm?
Like an MOU?
Yeah.
Memorandum of understanding.
Yeah, or an actual operating agreement
Hmm.
that has teeth to it, so that you have to share, and you share for the not just for getting the chip done every time, but responding to the chip. Like who looks at the chip after it's been created, and if we're not on track, fixes it midstream, or do we just wait for another 3 years and redo the CHNA and the chip again, which is what we've been doing. We just redo it every 3 years, and nobody's accountable for the results. Of our assessments, and we're spending a lot of time assessing, but we're not doing much fixing. And again, here's another idea. IUND district, those people were displaced, and they found out that they were living 20 years less than other people in other communities, and they formed a consortium with diverse funding, non-for-profit. All kinds of people were involved. They have the advantage of Unigov up there. We don't have that here, but Unigov, took care of a lot of these kind of barriers to care. So my plea is that we consider finding some other kind of a way that's not aligned with politics, so that we're not at the whim of the legislature. I mean, if they cut that funding in 2 years, what would we do to replace that? Start a new program and then not have any funding for it and let it just die? Or do we want to find some way to make ourselves more insulated against political ups and downs? So obviously, I think we should consider forming some sort of a consortium that involves the city, the county, the hospitals, the primary care doctors in practice, all the other entities that community benefit organizations under some sort of a banner, so that we can share data, at least with each other, analytics and things, and and be able to share quality data and safety, and why were those 3 girls laying in the intersection the other night for several hours bleeding without an ambulance? How do we fix that? So
it's gonna require a new legislature. We're currently third worst state in the union for maternal mortality.
Right.
We're seventh for infant mortality. There's no-
But can we depend on the politicians to solve this? I don't think so.
we're driving physicians away.
Yes. Yeah.
And that's, some of that is politically driven.
And some of it's
And-
being an employed physician and not having a voice.
Well, and the politics of healthcare, there's restrictions for care that impede improvement.
And most of our physicians are leaving. They're not. So anyway, I haven't given this talk to anybody else but you guys, so I'm probably gonna give this talk to some other people and talk and see if there's any interest in forming some sort of a coalition that would bind us together a little better.
And can we get a copy of your slides,
Yeah.
please?
I'll send it to Dr. Pritchard.
Most of those slides are.
They're very similar.
We have them in an email.
I just updated some of the data and there's been updated. I went in and had to change some of the figures.
Yes, I sent an email out a couple of weeks ago, and both of you had
Sorry.
the article and the PowerPoint.
And this is the publication that my group put out a couple of years ago. You probably saw it. It was based on a research grant that Metcalf had and CJM had.
Lee,
Here's a copy of the slides too, if you want.
you talked about an umbrella, which is great. I think that indeed having everybody at the table might be really helpful. But you also alluded to the fact that we have no real control over that money, and we know that the politics are constantly changing, and that it seems every 20 years after something awful happens, suddenly there's money again, and then it disappears because we've got other things we want to pay for. So I'm wondering, how do we manage, even with an umbrella, to finance what needs to be financed in terms of healthcare and responsibility to our public?
Well, part of it is, most of these grants will not, they want to see a group of people who are working together before they contribute to a coalition.
Yeah.
And so we have to find some way to form a coalition. And I think, unless somebody's feet are being held to the fire, nobody's holding your feet to the fire because of the infant mortality rate directly. So who's responsible for that? I mean, the doctors? I mean, who's responsible? So if we had an entity that could take that responsibility on, the future of the payment system is going to be value-based purchasing is what they call it. I don't like it. It kind of sounds like HMO to an old guy like me, but it's basically going to be value, like the cost of care divided by the quality, basically going to be the value. And so you have to protect your resources as much as you can, but you have to still maintain quality. It's very difficult. And I think we need an organization that represents those values, and because it should tie all these other groups together. We don't have anything like that now. We're all working in our own places very well, but we're not really working like we did during COVID. And COVID is what uncovered a lot of this crap,
Again,
Yeah. So we tend to react like that. That's how most patients react, right? They don't come until they're sick to see you. And we would always rather they came beforehand so we could prevent the heart attacks. So that's what we're.
If you look at root cause, as long as we treat healthcare as a commodity instead of a public utility, we're gonna have a lot of problems.
Yeah. So we'll see. So I'm gonna be beating the bushes, see if I can find anybody else who's interested.
Congratulate you on what you're doing.
Yeah, thanks for,
Yeah, we'll try.
it's great. I
Thanks for
wish
your
we
time.
had more time
That's okay.
actually to talk about this, but I really feel like this is, that you've really hit a nerve here.
Yeah.
That's a dentist saying that. I think it's something that we really do need to, form some more, well, I don't know how you, relationships with people that we all have similar goals
Right.
and,
But they're gonna have to be tough relationships so that we feel like we
yeah.
can't just blow it off.
So I certainly, I think, we should follow up on this and with, maybe we could form like a committee to help, because we obviously can't meet and, the whole board can't meet all,
Yeah,
away
no.
from here,
I
but.
just, I'm just, appreciate the time. Thank
Yeah,
you.
well, yes, thanks so much.
Thanks, Lee.
You're welcome.
I think you've shown some real issues, and I think it's a lot of issues that we're grappling with, trying to figure out how to help our community. So,
Yeah, as I read through the PowerPoint again today, the one thing I kept saying, well, I don't know. I mean, I don't know. And I was embarrassed. That, yeah, I don't really know what, how we do this. So,
But if you did know, you would just fix it and the whole world would be much better. I mean, that's the.
but getting
that's the
other people to
problem,
come
right?
together.
Nobody knows.
To form a
Didn't
real
last chip
solution to the
identify
problem, I think
access
is
to
the
care as
issue.
the number one thing?
Well, the
Number
ultimate
one
power
and
to
number two,
give,
consistently.
Yeah.
IU Health has to, I'm not picking on them, but they have to check a little box at the bottom of their IRS form that says that they contributed significantly to the community, enough so that they get this tax deduction. And there's a few communities who are not allowing the IRS to allow them to check that box. So the threat is that they have to start paying taxes like everybody else. That's a for-profit. They don't want to do that. That would be a very antagonistic way of addressing the problem, but it comes down to that.
Yeah.
In some communities, they've had to say, we're going to protest the IRS that you should not be a not-for-profit. And, that's a real threat to the survival of an organization. And I don't think that we need to start with that.
No,
but
no,
That's where it ends up in some communities that I've read about.
important safety tip, but
Yeah.
but probably not where we
No,
want to
no.
start. Yeah. All right. Well, thank you so much again.
Thanks,
Great
Lee.
information.
thank you, Rick.
You're welcome.
Is Lindsay still with us from, Public Health? Oh, there you are. Yeah.
Good to see you all again.
Yeah.
Thanks for having me here. If you don't know me, I'm Lindsay Shipley. I'm the nurse supervisor.
We're used to seeing you up there.
I know, and I'm in person today, so.
I know when I came in, it was like, and then I didn't see you up there and then.
Yeah. So, that was a great presentation. It made me think of the reason why our nursing clinic does what we do. I mean, we can give you numbers, we can sit here and give you numbers. Oh, we had, interaction with this many people, we vaccinated this many people, we did this many outreaches. But I can't tell you the time that we spend educating patients. That's our role. We don't have a physician that goes around with us to areas. We don't have a physician working in the clinic. So the amount of time that our nurses spend educating and advocating for these people who, some of them have no voice whatsoever. Some are, immigrants to this area. We have to help them navigate and find care to different areas. And so the work that we do is vitally important in helping, the healthcare system. Because if we can but if we can prevent and direct them towards care, educate them, these are reasons to seek care. These are reasons to go to the ER. Then that helps the healthcare system not be overloaded by all these people who think that they are, sicker than what they truly are. So I'm gonna brag on my nurses because they do a heck of a job doing that. And so the work that they do, it's incredible. It really is. I can't say that enough. I even have nurses, the one who's with me today, she speaks Spanish. I have another one that speaks Mandarin. So when we go to outreaches, those are breaking down huge barriers with those patients. So, yeah. And so you see a list of outreach events that we've had. Do you guys have that? Access to that? So these are ones that we've done, minus the schools, since, late September. I'm gonna highlight just a couple of them. Beltrace, so that was a big clinic for us. We typically attend more outreaches at the nursing homes, but there was an agency that came in and picked up for a lot of them. So, but we had a good turnout for Beltrace. We had our first drive-through clinic since under my leadership. That was, late October. We had zero expectations of how that would go, but we had a good turnout. So that's a stepping stone for us to, do, bigger and better things for next year. So we're very much satisfied with that. And then, most of our team had never, been able to go into the jail to administer vaccines, so we did that yesterday afternoon, and it was good. The people were very appreciative, and so we enjoyed being there. We attended 25 or we went to 25 schools for flu and COVID clinics. The response was great. I think the pediatric offices really gave the information out to parents very well because it eases the burden of their clinic. Their nurse schedule gets overwhelmed with the flu and COVID shots. So we gave over 1,300 vaccines at the schools this year. And then the total of 2,532 vaccinations, whether that be in the clinic or outside of the clinic, in September and October. I think we had, I think it was over 1,100 patient encounters in October alone. So that was good. For 2025, my group is working on goals, but we are going to try to focus on being more embedded in those higher risk populations. So the elderly, the homeless, the ethnic groups, and go there more regularly so that we're a familiar face for them. So I think so far this year, we've had, I think next week we will hit 70 outreaches that we've done throughout the year. So it's been a busy year. We're still trying to exhale a little bit from our flu clinics that we did at the schools and different outreaches. So as far as immunization updates for the fall vaccines, we have good supply of all those. We are giving a fair amount of Arexvy, which is the adult version of the RSV. They have to be 60 and older for that. So we have that. We still have good supply for those who are uninsured adults. We, as a Vaccines for Children provider, we have been advised to keep a couple doses of the Beyfortus, which is the RSV vaccine for infants. So that's new to us. We've not carried that before. And they can receive that up until 6 months of age. So we do have them on hand if anybody needs that. As far as lead updates, we currently have 8 confirmed cases. I think your page just said 6, but we are up to 8. So they're receiving case management. Everybody wants to know about flu and COVID. So there is a little bit of flu A circulating, but the numbers are still low. COVID numbers are still down. RSV is increasing. So keeping that on our radar. As of November 9th, so the state said minimal flu activity throughout the state with 0 flu deaths as of date. So no outbreaks other than, seasonal things at this time. I did include some COVID graphs for Indiana. And it shows the wastewater, which is down to TB. We currently have 0 active cases, which is great. And then the latent TB, we have 24 cases that our nurses managing. So as far as any other updates, we did have a position to backfill. We had a nurse that left in September. We have somebody hired. She is training and up and running, and things are going smoothly. Her start date was November 6th. So that's going really well. Questions for me?
Just to remind myself, if I recall correctly, RSV is a one-time vaccine.
It is currently. Mm-hmm. Yeah.
So you don't need boosters for it like
Don't
you
need
do for
boosters.
COVID.
No.
Flu.
And the CDC has already approved, for those 65 and older, you can get a booster of COVID 6 months from, when you receive the last dose. So people have that on their radar and things are going well. Questions?
Questions for Lindsay? Great, thank you for,
Thank you so much.
Thank you.
I was told today that the statewide vaccination rate for COVID's about 17%,
17.
17.
Okay, I'll stand next.
Nice. Okay, Lori, it's
Sure.
update.
Yes. So as far as employee updates with positions, so Jessica was previously in the assistant registrar position. She has now transferred into the new assistant director position that we recently received approval for. The health services director position is on the council agenda for next Tuesday. So that will go in front of the whole council to request approval to be able to post that position and fill it. Still accepting applications for the Director of Public Health Preparedness position. And our full-time environmental foods position, we are going to be transferring Peter, who's currently part-time, into that position in December. He's currently splitting his time between wastewater and foods, and he will continue doing that in the full-time position as well, just to be able to help with the high demands in wastewater. Our second medical resident finished their time last week. She spent a lot of time kind of updating some of our safe sleep educational materials that Vital Records hands out and distributes in the community. I spent a day a few weeks ago at the Vanderburg Health Department, touring their STD clinic, learning about the Pre-to-3 program, some of their different programs, toured their mobile unit, and got some information on that. So that was a really good experience. Aubrey has moved into the maternal and child health new position. She's spending a lot of time going to different community organizations, introducing herself, learning about the services that are being provided, looking at doing some partnering with Mother Hubbard's Cupboard to provide nutrition, education, and cooking classes on site there as one of her programs that she's working on developing. Let's see. The state has extended the implementation date requiring local health departments to issue birth and death certificates from every county. So that was something that originally we thought we were going to have to begin doing in 2025. They've now pushed that date back and looking at the end of 2025. Some of the main issues are deciding which health officer name would go on the certificate and what the fee would be that we would charge, whether we would charge our local fee or the fee from the county where the certificate actually originated. So kind of relieved about that. Christina, Avery, and Aubrey all attended a health fair recently at Switchyard on November 13th, providing car seat safety checks and educational information. Avery has been assisting with vaping education in 5th grade classrooms at 6 of our local schools, around 250 students. She currently has 34 participants in the Quit for Two smoking cessation program. And to date, 13 babies have been born tobacco-free this year. With environmental, they're getting prepared for winter farmers market inspections. They are continuing to update the monthly food inspections in the new GIS online system that we recently worked with the county with to get started. Let's see. We are working on trying to start a program on meth contaminated properties to have testing done of that and to identify which homes can be cleared from the list and which homes need to have the remediation and the cleaning. ARPA, so 3 of the septic installations have been completed as of today.
how many, do you know how many are available still of those contracts or the funds?
I don't know a specific amount. I could check with Shai, but I think part of it is, it depends on the cost.
Mhm.
So, but the county did a lot additional funding. So I believe it was nearly 1 million that they've set aside for that.
So it's still, people can still apply for the funds, okay.
But my understanding is that all the paperwork has to be done by the end of this calendar year. Is that right? That everything needs to be completed. The funds can be spent later, but
We can complete the work later, but we will have to be like under contract.
by the end of this year. Which
Yes.
means that, do we know how many are pending at this point and whether they will be completed? All that paperwork will be completed by the end of this year.
Mhm. That's something I will check on. Let's see. So Eric, who recently began in wastewater, is going to be attending orientation in December. And everyone in environmental is working on their annual report goals. Everyone in the department, each division has completed their draft KPI for 2025 that was due to the state for submission. So I'm waiting to hear back on approval for that. So I should know more in December.
And how do those KPIs fit with the whole departments?
Mhm. So, aligned with one of the core services. So, like harm reduction is focused on reducing the mortality rates with opioid. Aubrey's work focused is on, preterm births.
Do
So,
we have a big picture of that, of how each section, or will we at least have a big picture of those KPIs and how they fit in so that we'll be able to actually follow them over time?
like tracking.
Yeah,
Yes, so everyone has to track and submit data on a routine basis, and we'll be checking that on a monthly basis and tracking that over time to make sure that we're meeting it. And are the plans that they're action items that they're actually working on working, or do we need to reevaluate and try different actions?
How many meth lab sites have been reported recently?
We have 13 total, but that's been since 2010, from my understanding. Just, yeah,
how many have been remediated? Do we know?
none.
None. Okay.
Yes, so current, from my understanding, previously, this wasn't work that the health department was doing. But it is something that our general environmental employees are really passionate about doing, so I think it's a good idea.
Thanks.
Is that it?
That's it.
Any other questions for Lori on the general overview department? Who does the math house? Is that environmental?
They can't, but we would have to contract you have to have a certified individual, so we would actually have to contract that out to go in and do it. We are not certified and qualified to actually do the testing.
Okay.
Mhm.
This would be rather, even if it was already mitigated at some point, then you still have to have the test at the end.
Basically be able to clear off of the list that we have access to and that we maintain, that yes, the levels are low enough, they can be removed from the list.
Okay.
Mhm.
And when was the maternal child health position filled?
Gosh, it's been, November is when she started, at the beginning of November.
Okay, and who is she?
She is Aubrey Jones.
She is awesome.
Okay, let's go on to continuing, old or continuing business, IU Health Nursing Contract. So we've been looking at that for some time. And Lisa, I think I just saw your hand move, so I
Yeah.
assume you have questions.
Discussion items. I have 3 discussion items. Do you want me to
Sure, go ahead.
bring them all up and then
Yeah.
we can
Mhm.
discuss them? Okay. So the first one is on 8B on page 3 of the contract. It says that the public health clinic will address one key performance indicator that aligns with the health department core services. So I think that item needs to at least be changed to 6 KPIs, because based on the items that they're working on and the people that we are helping to pay for, they could report on tobacco cessation, access to care, chronic disease, immunizations, health emergencies, and tuberculosis management. So that would give us a lot of data for 6 KPIs instead of just 1. And that would allow us to meet some of our criteria. So if we're gonna pay whatever amount we agree upon, I think it's reasonable to ask for data for those 6 KPIs instead of just 1.
We received the data for all of our vaccines, TB, tobacco. We could do with the school liaison. She does education, but we don't actually pay for their tobacco programming, I guess.
Mhm.
Let's-
But my point is, if we're gonna pay whatever the amount we agree upon, there's no reason why, with all of these things on page 2, there's no reason why we can't ask for 6 KPIs to be reported on instead of just 1. So that we have data.
Are you basically saying, and I apologize, I haven't read it, are you basically saying we're paying them to do this work?
We're paying
therefore
them,
They
with
should
the
report
metric.
on
Sure,
the work that they're doing.
to me, there's no reason
Perfectly logical.
why we can't ask for 6 KPIs instead of 1. That's my first concern.
Comments on that?
That's great. I think the more data we have,
Yeah, I mean,
the
that
more we
sounds,
have to work with.
It doesn't.
to me,
sound
that sounds reasonable.
Unreasonable at all. It doesn't sound unreasonable.
So do I make a motion that I'm asking this, do I make a motion that the board asks in terms of contract negotiation that the language be changed? Is that how that works?
Yes, we could put that in the.
To amend the contract.
Right.
So I make a motion that we amend the contract to say that item 8B includes 6 key performance indicators instead of the language of 1 key performance indicator.
And do you want
You wanna
to
reference-
specify them?
Yeah, do you want to reference the ones that we're paying them to do? It might be nice to kind of tie it together.
Do you think, I don't know, is that appropriate?
Yeah, sure.
Yes.
Okay, so that would be tobacco cessation, access to care, chronic disease management, immunizations, health emergencies, and tuberculosis management.
I second.
All right, it's been moved and seconded for the 6 KPIs to be included in our metrics for purpose of amending the contract. All those in favor, please say aye.
Do we have to ask for further
Aye.
discussion and see if there's anybody online and all of those things? I'm just asking.
Sure. Anyone have comments? Sure, yes.
Instead of chronic disease, communicable disease would be better.
But it's-
Well, I disagree with that because
In the
chronic
contract?
diseases,
Hypertension.
hypertension, diabetes, lipid management, all of those things that you all are already collecting
Okay.
data on.
Cause I didn't know, cause, Sally does specifically communicable disease,
Mhm.
so.
Add that.
So then we would make it seven
I
KPIs.
just was recommending to change the wording of the. And I think it should align directly with
It should
what
align
the
with what's in
contract
the
says we're
contract.
funding them to do.
Mhm.
So the
Well,
contract says we're funding them to do chronic and not communicable.
We have communicable.
I was just looking at the KPIs that are listed for the state, and certainly, you know, chronic disease management is one of those. So I think we need to decide as a group. So maybe it's 7 that we,
Unless we make it TB and other communicable disease. We could do that as well, couldn't we?
Yeah,
But
because one of the KPIs is tuberculosis management. I don't know that specifically the KPIs say communicable disease. I don't know. the
it's under
answer.
disease prevention and health. So chronic is under disease prevention and health education. And then there's a separate one for communicable diseases.
Okay, so we should do 7 KPIs.
Well,
If communicable disease is separate, then we should include it.
it is in our tracking, and well, it's on here.
Yeah. So
And then
I would
TB
agree.
just falls,
Is that a
TB
duplicate?
falls under
Under
that.
communicable disease.
What's
Is
that?
that duplication?
Mm-mm.
No, tuberculosis management is separate.
I thought you said it was in. listed
It's
somewhere
on,
else.
it's listed under the contract, but in
Okay.
the state, it's separate.
Okay.
Okay, so
We're already amending the.
my amendment is to provide reporting on 7 KPIs instead of 1, to include communicable disease, tobacco cessation, access to care, chronic disease management, immunizations, health emergencies, and tuberculosis management.
I second.
Any further discussion? Hearing none. All those in favor of the motion, please say aye. Opposed?
And thank you, Lindsay.
Yeah,
I think you.
and yeah, so, just gonna make a notation here that it's 7. Okay. All right, you had,
I have
Next
2 more items, yes. The next item is the issue about VaxCare that we talked about, I think, in September. So my number one concern, so we had talked about this 80-20 split, that Monroe County Health Department is getting 20% from the VaxCare contract, and Community Health Services is getting 80%. But my concern, when we actually got some of the budgetary line by lines for VaxCare, show that Monroe County taxpayers are paying for things like Carmichael hotel fees at the tune of $500 per person to go to various conferences. So if we are paying for that as part of the budget, the VaxCare budget, that was in the information that was sent to us, I still am proposing that the contract say that instead 80% of the reimbursement go to Monroe County Health Department and 20% go to Community Health Services.
Did anybody follow up and find out about the 80-20 and where that figure actually came from originally?
I think it was determined, we tried to follow up and we could not find out where the split came from.
It just was
yeah,
all,
we went back.
we went all the way back.
We went back and we had that in some of our information in the past and it really, there was never any justification. It's just there.
And so I wouldn't want us to then arbitrarily, it seems, say, well, let's just flip it and we'll get 80
Okay.
and they'll get 20. Like, I would like there to be some basis. I support what you're saying.
So I don't, oh, go ahead.
I don't know what the basis would be, but it would be nice to have a basis for the split.
Is there any way we could contact Penny Cottle and see if she remembers when it was 80-20?
Sure, I mean, I could call it.
So in this, but in this line by line, we did receive the budget, correct? Part of the budget for VaxCare, some of the information. So, I mean, are we okay with some of these line by line items that, I mean, like if our people went to a conference, I would think they would, you know, 2 people would stay in one room or, you know, I think it's a lot to ask the taxpayer to be paying for these items when this is a vaccine contract and we need to be helping people in our community for their vaccines, not paying for expensive hotel rooms is all that's my point. So
Typically, when you travel on a government budget, you're limited to what you can pay for
but I'm
hotels and.
right,
And,
well, that's
and
fine.
we the board, we don't control that, like
right.
the county or the state would control what the max is
Okay,
that they're gonna pay for. So I'm not,
but we're
I guess
also
I'm
the gatekeepers
confused.
for the for this this piece of the contract negotiation. We are, as the board, able to ask questions about this 80-20. And so I feel like then we should ask for more information and a specific line by line budget, you know, how much money is coming in through VaxCare, you know, an entire budget so we can look at it and evaluate it and then make a decision about whether this 80-20, I mean, maybe it does make sense, but I think we don't have enough information.
agreed,
We still don't have enough
we
information.
still don't have it.
Typically, when I've gone to a conference or whatever, they have reserved a certain number of rooms at a certain hotel for their applicants, and that's where you stay. So maybe that's it. I don't know,
Mhm.
but I'm assuming that's what happened.
Well, overall, I see this as a function of, there's a big jump in the ask for, and this is something, you probably know, Lindsay, but you know, IU Health is asking for a rather large increase in the fee this year. So that's prompted a closer examination of the costs involved, because we're trying to see what the justification for, which basically was what?
50,000, extra 50, 60,000.
Yeah, like
60,000.
$60,000. Why this huge increase over a 1-year period? And do you have any information on that, or?
I'm not gonna share any information.
But anyway, that's, we're not trying to put anybody on the spot, but you could see from our standpoint, I mean, that's a really big jump in 1 year. So,
So how do we get that information? Who do we speak to?
well, I think, that you have
Amy.
Yeah.
And I think some of it was, there was, COVID grant money they were receiving, but now we know all the COVID grant money has gone away. So, and I'm assuming that, I think it was like 3 years, got that additional funding to help additional like employees and staff and such, but now all of our COVID grants have gone away. So I would,
but COVID isn't the crisis that it once was
Right.
too. So, but it seems that all the expenses are still there. So,
And they're asking us to pick it up.
yeah, exactly. So, I think that's all the justification we need in asking for, a closer accounting of what these expenses are. I mean,
And it goes back to what Lee was saying to us about, okay, IU Health is a not-for-profit, is not paying state taxes, and is accountable to us for their not-for-profit status. Why are we asking the county to pick up whatever this extra money is? Is it simply because we have Health First money and therefore we should be paying a lion's share of what's going on? I mean, what is the justification?
I don't know, but I think that when is that, time that you have set up? Don't you have time set up specifically to talk to Amy about this?
She said she could meet anytime, really, so.
Okay. Because I think there should be 2 or 3 of us go and, on that meeting, so let's coordinate. George, you going to say something?
Well,
Okay,
you had a third point. didn't you?
Well, that was about the amount of the
Oh,
contract.
the amount, okay.
Yeah, so,
Okay.
so, so then so we'll all, have our meeting in December and then we'll discuss this again as to whether or not we're going to sign the contract or agree to the contract?
well, we're down to the
Yeah,
wire, at that point, so,
you're gonna have to.
yeah, I think that, yeah, we'll have to. I think, along with Amy, I mean, Amy's probably not, maybe we could, there was a vice president, that reached out to me concerning adding additional services. And I pointed out to him that we didn't have, all this additional money, that maybe he thought that we did, and that we were looking for additional services right now, is that we were more closely examining the contract we had for our current services. And, so he said, well, maybe we could, get together and talk about something else in the future, but, I think maybe we need to also have someone maybe that actually goes beyond Amy at this meeting as well.
I would agree. Is it possible to do this before our December meeting so that we have an answer?
Absolutely, we want to do this. Yeah, we probably want to do this as soon as possible.
So then I think we need to have another meeting, or if you want to gather data, then we should have another meeting with all of us to decide, the Board of Health to decide what that amount should be, what we think is the right answer to in the negotiating the contract.
Okay, well, we'll see about having another meeting, but let's get this meeting set up first. And then, once we have maybe some answers,
I think,
and I'm thinking on the run here, we're gonna have to, if we're gonna question what this is, then we need to give them the information and ask them these questions prior to that meeting even. And they
Yeah,
have to-
because it's gonna take.
Yeah, they're gonna have to put
get
some,
their
yeah, they're gonna have to put some
information to give us an
information.
answer. And
I think it's unrealistic though to expect us to vote on December 9th without several things happening ahead of time.
December 9th.
Yeah, isn't that our December meeting? It's,
19th.
oh, sorry, December 19th, I guess. Are you sure?
It's the third Thursday.
Yeah, I think it's the.
Okay.
It's the 9th.
19th.
Do you?
Okay, so anyway,
The 17th, okay.
we'll discuss setting up a meeting with, Amy and whoever else needs to be included. Good points, all good points. Yes, we do need to have a discussion then after that meeting, but prior to our board meeting.
I
So-
think Amy would have a good idea of who else to invite
Sure.
at that meeting.
Exactly. Okay, so you can arrange that, right?
Mhm.
Okay. Lisa, did you have anything else?
No,
I thought you had 3.
She
I
did,
did.
she did 3.
the
The
third
third
one
was
was
the
the
amount.
amount.
Okay.
We kind of,
Together.
jumped the gun on that one, so.
Yeah,
Together.
it is the 19th. Okay, great.
And it's frustrating because Lisa raised this a couple of months ago and we still don't have answers that we really deserve to have in negotiating this contract. And that feels really frustrating for me, and I'm sure it is for Lisa as well.
Okay, did you tell me that the school liaison contract is something that we're,
Yes, it's in here, so. Yeah. So the only thing that's been changed is just the dates with this and the time period. So it was following the grant cycle previously, but this change will allow it to just run on a calendar year. So our current one that we were in was a 6-month agreement, so this would be a new annual contract beginning January 1st.
so otherwise it's pretty unchanged, other than dates and
Mhm.
so do we need further discussion on this?
Vote on that?
Yeah, are we
Are
we ready to vote?
We accept the version of the,
I
school
have I
contract.
have a question first.
Well, I'm going to make the motion, then we'll have some discussion. How's that?
Okay,
I move that we accept the agreement for coordinated school health services for the amended date, January 1st, 2025 to December 31st, 2025.
Second,
Discussion.
so we voted on this contract previously.
Correct.
No discussion. Thank
Well,
you.
not,
We've already voted to accept the contract. This is an amendment. Is that
this is
correct?
just changing the dates.
Yeah.
And making an annual rather than a is it a semi-annual?
It would.
6-month contract.
It was, but the purpose of that was to then be able to get it on the same, yeah. So, and I did, the only other, change to this was, H, so item 7H. So stop the bleed training. We have someone here at the health department that, is, qualified to do that. So, to refer those services to, Christina.
So I think we need a
Okay.
second.
well, we got a second, Sarah.
I seconded
Oh,
it.
okay.
Yes.
Yes,
what-
Dave?
Have we ever, just, wasn't there an issue with the fact that the person that's doing it works for IU Health? And wasn't there some stipulation that they had to be an employee of the health department?
Well, they're supposed to be representing the health department brand. So she does have a health department badge, now,
Okay,
but it's supposed to be the health department, like as a health department representative.
But she goes out to do the things that are included in this contract. She is representing the health department on, and so she
I
splits.
don't have a problem if
Yeah.
the agency that we're responsible to, doesn't have a problem with it.
All right, any further discussion? All those in favor, please say aye.
Aye.
Opposed? Motion passes. Monthly report. Have any?
Um,
Yeah, you should have, September and October information report. Document.
those are, just our work activities, just to approve that as part of our process.
The,
Activity reports from September. and October.
I mean, this stuff in,
There you go.
yeah, these things.
Mhm.
Do we approve those or
Yeah.
do we accept them?
Except,
Well, I think that was the thing.
I move to accept the monthly activity reports for September and October.
Second,
Discussion on the accepting the reports as presented. All those in favor then of the motion, please say aye. Opposed? Thank you. All right, our Health Net Partnership Agreement. Now this, I think this is the. Is this the one, is this the homeless one or is
Yes.
this the other one?
that is the homeless, initiative.
Okay.
Yes.
Is this new?
So, that's
Yes.
when they came to the September meeting, and talked about, starting this programming, expanding, services to be able to help at the shelters.
Between the hours of 5 and 8, 3 days, I think 3 to 4 days a week, sometimes available during the day. That it was spelled out pretty great detail. My impression is that I think it's a real step forward. I think it's money well spent. Well, I mean, that's my assessment.
I'm remembering I wasn't at the September meeting, which is why this
Yeah.
all is new to me, so. Sounds good, guys.
So, so Lori, on page 2, or sorry, or page 1, number 2, it talks about reporting and metrics for this program. So which KPI would this be associated with?
So this is, the access to care.
Access to care.
Mhm.
Okay. So,
And will also, if there are ones that, if they're not providing like the referrals, if they are going there and doing like the blood pressure screenings, they would be capturing that data. So we'd still be submitting that as well. So any of the services, and some of them can be, submitted to the state as paramedicine.
so does there need to be specific language about exactly what needs reported or in a fashion so that it's easily transferred to the KPIs?
That's, so how it's listed A through E, that kind of lines up with how it will be submitted.
Okay.
So, and that is following like the pattern. So
Okay.
number of events, individuals served. We are going to be trying to capture, demographic data, and then the services offered.
So I would like to talk about, so the original meeting we had, my understanding was they were asking to make a part-time employee, which was the nurse practitioner, full-time. So that was and my understanding was that was the original discussion. But this contract has actually 3 different items for the $155,000. It's the $65,000 for the nurse practitioner. It's also $70,000 for an outreach navigator, and then $20,000 for additional medical supplies. So I think it's an awesome program However, I don't know that we should spend $155,000 to. So the direct patient care with the nurse practitioner, I think, is key. I don't know that we should, because part of this is to keep people out of the emergency room for IU Health. I don't know that we are responsible for paying the $70,000 for the outreach navigator, and I am just curious what the $20,000 in medical supplies would be. I just want more information.
When I said it's money well spent, when I was reading the proposal, the one thing that did occur to me is that the emergency department had said that the hours that they were most inundated by these problems were between the hours of 5 and 8 p.m. So that's when the program was. And because of that, if we are dedicating $155,000 to this program, we are taking, hopefully, some of those emergent type patients that would be presenting in the department, and taking those people off their hands, which causes them to have to divert a lot of their dollars or treatment time. I mean, money. I mean, basically what it boils down to is money. We're taking that over, basically, and while the population that we're trying to serve are beneficiaries, so is IU Health, because we're taking those patients, trying to keep those patients out of the emergency department, where we all know is the most expensive place to get care. And I was wondering that maybe there should be a little bit maybe of a partnership here, if they could, give us some sort of number for, as to how much they're spending on emergent care for this population. Maybe we had a little leverage to also see if they could do in some way participate in this.
And going along with that, if that's the intended goal, that's the reason for this whole thing, I would want to see the data. Like, I would want to see
What,
the ED say between 5 and 8, we see X number of homeless patients. And once this went into place, we've seen a reduction.
well, I would argue that that's not the only reason. I mean, we're trying to head off disease and not wait till it's an emergency, which then requires a lot more treatment. So I think, we're treating a population that has a need, number one, treating people that aren't fully functional in society. And oftentimes their diseases are put off until they're, yeah, anyway, there's a benefit, there's a human side,
Sure.
and there's the financial side.
But it would certainly
Of
be
course, but I'm
interesting.
just saying, I'd like to also see the data side. I mean,
Well,
if part of this is driven by the emergency department saying we're just inundated
Yeah.
with these folks between 5 and 8. Awesome. Tell us the numbers. When we put this into place, let's put some numbers afterwards.
Maybe Health Net would have some of those numbers. They weren't included in it. I don't think, were they?
And we're we're asking in 2E for data about the IU Health Emergency Department versus what we're seeing from the HIP people. But we don't have any before data to compare that with, to see if there's a drop. And it's also, I guess it's in alignment with what is being said. We also don't necessarily see the participation of IU Health in paying for any of this.
Which was what,
Yeah,
So,
so, yes, exactly. So, are they participating in any way, either in benefits, in which case we could take the benefits piece off the package? Are they making a financial contribution to this effort? And I don't know where we get that information.
well, I know in Centerstone Health Services, the FQHC lookalike here,
Mhm.
when we started our program, you need to have a partner, hospital. And IU Health refused to participate in that, and part of it, there may have been other reasons, but, part of the problem was, I think, that they were already participating with Health Net, but let's just say they refused to help. And I'm sure cost was one of the reasons. So it's only fair that, when they're asking us to take emergency patients off their hands, that there should be some participation on their part. I mean, I think that's what you're saying too,
Yes.
right?
Yes.
And is there a line item budget submitted
No,
with this? Well, why not?
It's the participation guidelines.
I could I'll ask her for one.
I mean, so 150, so on the last page, 155. So part of this for the nurse practitioner, outreach navigator, find assistance for medication, other medical costs, needs. Okay, so that should add to 150.
It does.
It does?
Yeah, I mean, very
Okay.
close to 150.
So salary, so there's the line item budget.
Mhm.
It's just isn't specified. So
I will say that the 20,000 was like an additional after they came to the meeting in September. And she that said that they could take that out if that was a problem too, just
Well,
as,
why don't we ask you to pay the 20,000? I mean,
So the other piece of this in this contract, I mean, C says, contractor is not to receive direction or supervision from any county employee or representative. The county will provide feedback and review any drafts. And then in D, it says, contractor executes this agreement as an independent contractor and shall not be considered an employee or agent of the county. Okay. But it's like, if this is a partnership to try to improve health in our community, then I don't think this language of
What?
that they can receive no direction or supervision, at least,
I think that's a liability thing.
oh,
I
I
think
see.
that's illegal.
Okay.
Yeah,
That's a
because
legal
because if
definition
we're
of contract.
providing direction and things, then we're liable, you know.
I see,
Yeah.
okay,
And then
So for-
they're our employees.
Okay.
They're not contractors.
okay,
I think it's a liability.
okay.
That's actually a positive thing. So
Okay.
we can't give them direction, but you know, we don't really want to be
Got
because then we're suddenly liable.
Okay.
Okay, so, we're not gonna vote on this obviously tonight, so we'll, I think that what we need to do is, ask, were you gonna talk to someone at Health Net? Ask them if, U Health mentioned a number at some point, that what their estimate of cost was. I mean, I know they have the metrics for all of this. They have analysts, that do the data.
Well, either costs or in number of individuals, number of homeless individuals.
Yeah.
Would
Okay.
satisfy me.
Okay, we're ready to move on to the next item. Purdue University Partnership Agreement. This has to do with, nutrition counseling and providing incentives for participation in this program up to 12 families. It's a $10,000 grant. And I first saw that basically $6,500 of that grant going to administration or account costs. It all has to do with people. It's a stipend for a couple students and some other things. And the incentives, like $50 vouchers could be spent at farmers markets, things like that, for healthy foods to provide counseling. Did you read I assume everybody read
Is this something we've ever done before?
no.
no,
Yeah,
I
okay.
don't recall it.
And where did this come from? Like,
Purdue Extension, so Purdue Extension does the Food as Medicine program. And they partner with the city of Bloomington Parks and Recreation for some of this programming as well.
They
Which I'm
have a
wondering if
big
that's why.
office over by the recycling center. Purdue
Oh, is that
Extension.
where, okay, yeah.
If that's,
Happy Thanksgiving.
thank you, happy Thanksgiving.
and if that's why farm stuff
This
is.
kind of looks like a week program for diabetics.
And Lori, do we have staff that could actually do this, just a
Yeah.
program like this?
I'm questioning if this is $10,000 very well spent. I mean, basically, it's
Yeah.
12 families and a family is defined as a minimum of 2 people.
Let's see, I had someone here in the department start doing some research on us obtaining this curriculum.
Mhm.
So we could use either this same curriculum to provide these classes or develop our own
Mhm.
evidence-based program.
Okay.
We would have the staffing capacity now with the new positions to be able to do that. It's just not something that we had up and going in the past previously.
I would vote we do our own because I think that's kind of plagiarism to steal their program and say, no, we won't.
We can do our.
So I would vote that we do our own.
I don't know, when I look at the budget, I don't see this as. I mean, I see what you're saying about, not very many families, but the budget at the end. Personnel and staffing, of course. Under consulting, it's not really consulting. There's student stipends who are gonna be doing the outreach. There's just a little amount for an evaluation, it's always good to have an evaluation, right? And supplies. I guess to me, when I look at it, I don't have the same concerns about. I mean, you do need people to run the program.
My concern is that could this program be run? Or if you're gonna do something like that, could it be done for an equal or lesser amount with a greater number of participants? By us, by someone in the department.
I guess is if we're working with diabetics, somebody's doing it.
Christina's position would align, with this because she's focused on some of the chronic disease initiatives. Aubrey is working on developing, programming for nutrition, but she's gonna kind of focus on some of those, maternal related.
It's okay, I mean, what you have more experience in these areas than, so. I mean, what's your feeling about this grant?
I was just surprised to see it because I thought it was work that probably was already being done by our department.
Well, I think that we probably should have been doing it.
Mhm.
Okay,
What are we?
So
No,
I guess the question is that something we can, and you feel like we can undertake? For equal or less money and get more bang for our buck? Is it
I
something
felt like 12 families was a small cohort.
I mean, the program itself definitely fits with our mission. And the program, yeah, it's something I
don't have-
think
yeah.
the health department could be doing, should be doing. Are we in a position to do it?
we have since we have the new position, we have the capacity to do it. We have the personnel, I guess.
So I'll make a motion that we just forego the agreement for Purdue Nutrition Education Services.
And look into doing it.
And look into doing it for ourselves through our department.
I'll second that.
Okay. Seconded, it's been moved and seconded, further discussion on this. Okay, you look troubled.
No, I agree that probably we don't need to have someone on the outside doing this, but I'm troubled if it's not being done.
I'm not sure why, but, I think that we could really expand upon doing a lot more here in the department with addressing chronic diseases and nutrition and obesity.
I know we have classes on smoking cessation. And for diabetics, why aren't we doing classes about diet and lifestyle?
There's this WIC program, which is run out of the,
The IU Health Community Building.
yeah. And that does the same thing. It hands out vouchers to people to use in community markets and do healthy foods. It doesn't target diabetics as such, but
Well, this kind of goes along with what Dr. McKinley was talking about, and I've talked to Lori about, is that we may not have to do this as a department, but we can encourage relationships with other people that already have these programs and make sure that they're keep moving along with our support. And when we look for ways to support them, and this may be exactly what you're talking about, that we could.
We're going that route, then I say the grant's probably very worthwhile.
And the extension service also has a whole panoply of programs. If you go online, you can get all kinds of nutrition information. They don't have a local specific course that they give, but you know, they're into it up to their hips. There are 10,000.
And certainly one of the things that I saw was utilizing particularly Mother Hubbard's Cupboard, which is already doing a lot of this food education in-house, and whether we can somehow partner with them in this healthy eating and change of lifestyle makes more sense for our own folks to be educating and helping people get the information they need. But again, utilizing health and Mother Hubbard's Cupboard and people who are like us in trying to create a healthier environment for the citizens of Monroe County.
So there's a motion on the floor and it's been seconded to not,
Motion again was,
to not support, this particular grant
And do it
and
in-house.
try to do it in-house.
And I'm just wondering, can you get back to us, Lori, and let us know how this is going to be instituted in-house? Because I think that we would all want follow-up on that decision.
Good point.
So in view of that, do we want to postpone a vote on this?
we kind of like to postpone, because I wonder how those 12 people were selected.
They haven't been selected, have they?
Maybe,
Just a magic
well, how
number.
did they come up with 12?
12 families, it would be just 12 people,
24 people? I
yeah,
don't know.
at the least.
I just,
They picked the
there's
number out
more
of the
to it,
hat.
I feel.
And that widespread, it's really interesting.
Okay, all right, so would you like to withdraw your motion?
Sure, I'll withdraw my motion.
Okay, sure. All right.
Do we need a motion to postpone the vote?
No, because we don't really need to do this until
Okay,
the last
okay.
one, or the last meeting.
It's gonna be a busy
It is
meeting
gonna
in
be a busy
December.
meeting, isn't it?
Hopefully it's not snowing.
Should we, spend all day and, okay, never mind.
And Steve, did we miss number 2?
Okay, I hope this next one's pretty easy here.
We missed number 2 though, right? The Health Net restricted donation agreement. We didn't.
Oh, okay, that's probably on the other agenda I had. That's the one I was talking about. That's the annual health net for maternal services, that I was thinking though, hadn't we in the last couple of years, that we raised that to 20,000?
I thought we
We
had
raised
increased it.
Yeah, I think we did one year,
We
but then
did.
we skipped last year because they still had funds.
Yes, they
Mhm.
still had funds because IU Health hadn't billed them. And even after they had requested multiple times, they still hadn't received a bill, which just boggles my mind. They didn't get billed, but nevertheless, did you have any discussion with them concerning the amount, 15? Okay.
So it's 50.
Well, then I would, you know,
So I have a couple of items for discussion. I mean, I don't know so can we have history on this? This has been a contract forever. Was that?
For many years.
long time.
Mhm.
Okay,
I mean,
They
It-
provide maternal prenatal care to
The indigent.
the
Uninsured.
indigent and uninsured, so
Okay.
people who have no resources at all.
Prior to this, it was Volunteers in Medicine, and Volunteers in Medicine saw only people with no insurance. If you had insurance, you couldn't go there.
When this Dr. LeBon did it one
Yes.
time, and
at that time. But he no longer is doing that.
right, it was no longer, and then Volunteers of Medicine started it, and then Health Net, I think.
That's right.
And they have given us reports in the past of how many people that they serve. And we actually took a look at this a year ago, possibly, because we had probably the same questions that are rattling around in your brain right now. And we were all very satisfied that
Okay.
it was a good use of the funds.
We've asked them to come before us once a year to give us an update on how many they saw, and
Yeah, and
How
they
the
did a
funds
great
were.
presentation.
and at that point in time, we decided if we wanted to raise it or.
Yeah, and I think we did.
So I think, can we add language though that, because this will actually meet criteria for our metrics for maternal health. Is there some way to add that language to this for the KPI and metrics so that that's reportable?
Sure. So, we could add lines in there, like of some of that specific criteria to address that core
Mhm.
service. Uh-huh.
So I make a motion to add a line item to add language to meet metrics reporting for maternal health. Would that be,
Mm-hmm.
Second.
Thank you. Any discussion on that? All those in favor, please say aye. Aye, opposed. Okay,
So,
so,
can I
so,
just, if, I think we agreed to 20,000 last year.
We did.
And the question is, not only did they not get their billing, but does the money simply roll over if it isn't used?
Yeah.
Mhm.
And it doesn't say that in here.
They've always used it.
yeah, they've always used it, but I'm not sure that they used it last year, which may actually, did they suggest 15,000 this year?
No, I actually just found, an old contract.
Because I think when we first started, it was 10,
It
Oh.
was 10.
yeah. And then we raised it to 15, and then they were using it, and I had a conversation. I went to Health Net, or, well, it wasn't Health Net then, Volunteers in Medicine, still Volunteers in Medicine, when we raised it to 20. And talked to Shelley, and she said, yeah, she thought I was coming to talk to him to tell him we weren't gonna give him any money. She was panicked.
so is there any reason in this, it says this agreement is irrevocable? I mean, does that, I mean, what if there's no health net, or it says, is there an issue, does anyone have an issue with that the agreement is irrevocable for any reason? I mean,
Who writes these agreements? Presumably the
Legal.
attorney prepared this.
Yeah, right? Yeah.
well,
So, I mean,
And our attorneys have reviewed this?
Mhm.
Okay.
Well, it's like,
so do we have information then that they spent the money last year? Someone's met with them since it went from Volunteers in Medicine to Health Net, or is the,
that happened several years ago, so, yeah.
Mhm.
And I don't know if we've had a report from them yet this year.
I think we have this year, but I can't remember when. It was like maybe a middle of the year, but I could go back and look.
Mhm.
Uh-huh.
They are reporting, they're not just taking our money and
I
not
got
reporting.
okay. But it's an awesome, it's awesome. I
Yeah.
mean, it's
Yeah.
a great service.
I would say just this, tell them that their contract this year is for $15,000. It's gonna be $5,000 less than what they've had floating around. Funds or something, and
Uh-huh.
ask them if they spent all the money that, you know, that, because it seems to me that when I looked at last time at the accounting, that they had not spent all the money.
Mhm. Right, because and that's why we didn't give any last year.
Yeah.
Mhm.
We didn't give them any.
We did.
I thought we did.
I thought
I
we
thought we
didn't.
did too.
I don't think, no, because they still had money.
I mean, do the patients realize they have access to that care? Is that the issue that they were, I mean, I guess we need more information.
I think it was a billing issue
Oh,
From IU.
that they didn't use all the money.
IU didn't bill them, so they couldn't. pay.
They had,
That's-
because they knew they were gonna have to account for the money. And they had the services and they had the statements. But they knew that they had spent the money. But IU had never officially billed them, so they couldn't
Pay what they,
pay. And then they requested several times. I mean, how many times does a hospital not
bill.
bill you if you, especially when you're asking to be billed? Well, anyway, it just didn't happen for some reason. So, yeah, I think, if you called Shelley,
Mhm.
she could probably have the information, like, if not the same day, probably the next day. Yeah,
It'd be nice to ask her to come before us again this year and maybe just meet with her and say, welcome and,
considering that it's so late in the year, maybe even a written report, just something just.
yeah, maybe plan early next year to meet with us.
Yeah, okay, well, that'd be fun.
And how, I guess we have to wait till next meeting to determine whether we're giving them 15 or 20,000 in this agreement.
Well, I think we'll probably do.
I would think, go ahead and give them 15, and then when we meet with them, if we find out they're in dire straits because they spent the money and they've got patients that can't pay, we'll
Okay.
give them an additional 5,000.
So should we go ahead and vote on this?
That'll be. Go ahead and give them 15,000 now, and then.
I don't have a problem.
I'll second that if it's a motion.
Right?
Okay. Discussion? All those in favor, please say aye. Opposed? Great. Actually, we haven't actually voted on something. Right. Now, the next thing, it should be fairly quick. Obviously, the Futures Clinic is no longer in existence, so the medical director no longer has a job. But due to the termination agreement, we needed to give 90 days, but Dr. Britton graciously agreed to forego that. We have a contract here that was drawn, or a termination drawn up by legal, saying that its job would officially be terminated on December 31st. As of December 31st.
Actually, I think it was September
September.
4th.
24th? Okay,
It was September.
The,
okay. I thought,
it would have gone to the December, it had been 90 days.
there is this guy,
F.
track of this.
You might not have that.
Someone,
There it is.
So does this require any action?
Yes. We have to,
Move to accept the termination agreement for the medical director for Futures Family Planning Center.
seconds.
okay, it's been moved and seconded. All those in favor, please say aye. Opposed? Thank you. The next item was the Fair Labor Standards Act changes to the exempt positions. We were going to have a discussion about this tonight, but due to a federal court decision that placed an injunction against the agency in charge of this, this has been rendered moot, at least until that issue is settled in the courts. So. Is that all we need to say about that? I mean, there's nothing else, right?
Right.
Okay, the jail health services contract amendment.
So the county needed to make changes to their health services contract for the jail in order to allow us to go in and provide services or testing. So if the DIS are going to go in there, because the previous contract would not allow external agencies or individuals to come in. So the changes were made to that. One that was being proposed, from my understanding, was about the medication stocks. So I believe that we would want to just keep that with the jail, overseeing their own separate funding for for the medications.
I have questions. Is that this interlocal agreement for health department?
Mm-mm.
Okay, so what you're talking about is the thing that just says
Contract amendment.
contract amendment.
Yes, just.
Okay,
that.
this is problematic. Do you know, do you know who wrote this?
So our legal department.
Okay, so this puts us in violation of federal law.
Okay.
So we probably don't want to do this.
Mhm.
In what way?
Yeah.
The 340B program funds STD medications at a reduced price. They are not allowed to be used for prisoners in any type of correctional setting. So
The discounted.
the 340B meds, which are all the medications that you all have. You don't have any non-340B medications. So this is fine. Number 4, it says the jail's gonna be responsible for purchasing azithromycin, Herceptin, and doxycycline. What you can't say is the public health authority will provide bicillin and gentamicin. You can, I kind of want to turn off the camera. You can provide it, but you can't say it in a legal document as long as nobody knows you're doing it. A whole lot of people look away, but you can't have a document that violates federal law. So.
Well, they're probably, legal is probably not,
And
informed on the 340B.
No, it's very.
It's complex.
It's I wish I weren't informed on 340B, but.
I
But
didn't
yeah,
know that, and
so,
I think we send it back to legal.
so I don't know how you word it to get around this if we are being required by someone, either the jail or the county. To specify that if we can massage this in some way. So that it doesn't straight up say this,
Mhm.
we're fine.
Okay.
What would you
So
suggest?
this part's okay?
Oh, this is all legal, this,
Uh-huh.
because it says the jail
Yeah.
is gonna do, because legally correctional facilities are supposed to be purchasing their own medication for their own inmates.
But they're wanting to do that probably because of the cost. I mean, bicillin is
Right,
$220.
right. And
Uh,
gentamicin was really
it's
expensive when I
expensive,
left the
yeah.
program as well,
Mhm.
and the rest of those are dirt cheap.
Would we simply add these 2 meds to the list and then cross out the public health authority part?
Yeah,
You
because
could,
it
but
says
then
there may be
if someone at the jail knows about the 340B program and doesn't want to spend $800 to purchase bicillin, they may not want to sign this, is the problem. Because these drugs are super expensive, that's why they're down here. That's why correctional facilities try to get out of purchasing these. It's a rock and a hard place, guys.
Well, do you have a suggestion for one?
Honestly,
I'm just asking. I mean, there's,
if you could, if it would pass to simply say the jail should be responsible for maintaining sufficient stocks
Yeah.
of medications needed to treat sexually transmitted infections,
period.
period.
Yeah.
Leave it vague AF.
Yeah. rather than being specific.
Yes.
I like that.
If everyone,
Delightfully vague.
if everyone will agree to that, take out, take out
The
azithromycin, Herceptin, doxycycline, take out the public health authority.
Instead of saying the following, just say
Correct.
maintaining sufficient stocks of medications used in the treatment of
Of sexually
communicable-
transmitted
sexually
infection.
communicated,
Because
sexually
Sexually
communicated
transmitted infections.
diseases.
Yep, yep.
Sexually
Yep.
communicable disease,
Communicable diseases.
right? So that's a workaround.
Good suggestion.
Okay,
So can I ask how that is budgeted?
How is what budgeted? No,
Those,
not on a public forum. You can't ask me that question.
bad question.
So then are we gonna talk about this? Cause I don't know what this is either, and it's not on our list.
Yes, so this is just information because, so some counties, because of the Health First Indiana, requirements, and the DIS services, so counties who do not have their own, DIS to provide the services are, offering, agreements to those counties to provide services for them in exchange for funding.
Gotcha.
So Vanderburgh County is one of those. This was actually a draft, like I received a draft from them of some language that they had used that we could then modify to fit for Monroe County, if that's something that we want to offer to other counties outside of Monroe with our employee who is being paid from Health First.
Thank you. That makes perfect sense. Because we do in District 7 have counties that do not have STD services or GIS, and we have to serve those counties. So, good. Thank you.
So does this need a motion? to Modify the contract?
Oh, for the jail? Sure.
Okay. I'll move that we accept the contract amendment as drafted, except that under medications for treatment, we say the jail shall be responsible for maintaining sufficient stocks of medications used in the treatment of STDs. Point.
I will work on that.
I'll second that.
it's been moved and seconded. Further discussion. All those in favor, please say aye.
Aye.
Opposed? Okay, the motion passes. Board member comments. Aurora, didn't you have something that you wanted to mention? We were talking on the phone.
No, I mean, if nobody's interested, I just won't. It's like,
Well, we don't,
Well, how do we know if?
we don't know.
we did hold an after action review on the Futures Family Planning Clinic closure as we were asked to by Julie Thomas and Trent Decker. In October, and it was attended by members of the county health department, the board, Monroe County government staff, representatives from Monroe County Council, Monroe County commissioners, so that we could identify and discuss factors leading to the abrupt closure of the Futures Family Planning Clinic. We looked at events dating back to 2021. Go.
It was attended by three members of our board, one member of county council, and one member of commissioners. I think
And, our,
facilitator,
well, and Liz, and E was here as well.
yes, and
And health,
Monroe
Elizabeth.
County government staff. I didn't identify folks by name. Yeah.
Yes, well, I didn't
yeah,
identify by name, but I wanted to make sure that this was a discussion, a committee discussion, basically, not They were not a forum of any,
No, it wasn't a board meeting.
yes, it wasn't a board meeting or a council meeting or a commissioners.
Correct.
Yes.
None of those. We identified events that had occurred going back to 2021 that might have played a role in the closure. And we concluded that we had been experiencing a lack of qualified applicants needed to fill key positions. Subsequent performance of staff hired for key positions led to drastic reductions in the numbers of patients seen for services, as well as the amount of billing reimbursements submitted. And we identified that we had miscommunications with the Indiana Family Health Council regarding planning for a temporary cessation of Futures Clinic services to afford us time to hire and train new staff. And we acknowledged that the board and the health administrator would benefit from increased regular communications with Monroe County Commissioners and council. Anything you guys want to add?
Excellent.
No, it was basically it was an informative meeting, and there was. I think the whole thing could be summed up to much better communication was needed between our funding agency and our department.
But also.
In our inaction, in probably solving the personnel issues. Those things went on longer than they should have. And then basically it was taken, and then basically as I remind people, we did not close the clinic. That was actually done for us. And our intention was not to close the clinic, but to reset with new personnel and restart. But communication was a problem all around. There's plenty of responsibility.
What I really heard from council and commissioner was that they would really like to have heard about the difficulties we were having long before we got into very deep water. That they might have been able to in some way assist and certainly needed to understand what we were struggling with before they saw a public announcement. And that was troublesome for them. And that was a big piece of let's have regular conversations.
Well, HR certainly didn't cover itself with glory.
But
That became a problem.
nevertheless, the funding agency is now, with the mobile unit has been cited
At least once.
at least once. So
I keep looking for it. It's right
Well,
across
they-
the street. but
According to Facebook, they're coming regularly. I mean, I see their posts when they're gonna be here, so
Because
they seem to come every 2 weeks, if not every week.
And I
What day?
thought I read a memorandum that said
I don't,
that they planned on having a brick and mortar, actual clinic here at some point, but I haven't seen any actual physical evidence, but then again, they're not communicating with us regularly.
if we could get some notifications from them, we could actually post it with our.
Yeah.
With our, where Futures Clinic is closed, so that people know. Not everybody looks at Facebook.
well, who should I send those to then when I see them on Facebook, so that someone in the county can put them
We could
on
put
the
them
county
we could put
website?
them on our website. shouldn't we?
I,
Or would they look poorly on us giving actually some information?
I mean, I feel like I would want their approval to do that, but
Yeah. Well,
But
yes.
if it's public information,
You
if they're
can just
putting it
post
out
a
to the
link.
public,
No big deal.
then yeah. We should be able to inform the public as well.
Oh, I should send it to Cody.
Is that faster?
Linnea,
Yeah.
All right.
So when it pops up on their Facebook page, we do share it from our Facebook.
Oh.
And our Twitter.
Okay,
account.
so you're getting it. So it's being done.
I'd do that.
It's being done.
No worries.
But can it also appear on the door where it says we're closed? I mean,
We could do that.
I just think that people should have something other than they come to the door, say Futures is closed, and it's like, well, what do I do now?
It's on our website, because I went in tonight to see if our meeting had been canceled, and I found it Futures Clinic, and I thought, and I clicked on it and it said it had been closed.
Mhm.
So it's on there.
Yeah, but where to go now that Futures Clinic is
Next
closed
meeting
and.
They have a little blurb about they're trying to.
Yeah, but we
Transferring
need to-
the
Yeah,
services
but,
in.
but to know
You wanna
that
ask people
indeed
now?
there is a mobile clinic and when it, those things should be linked.
Yeah, they should, just like Dr. McKinley said.
Yeah, we need to
So the
do as much as we
12th
can.
though is a week earlier.
Well. Would, all right, any other comments, board members? If not, then I would like to propose a slight change in the date if possible. I realize this is a busy time of year. Our next meeting date would be on the 19th. I would like to propose that we meet on the 12th.
I will not be here. I'll be out of town.
I'm
Right.
flying out the 12th in the evening.
Oh, okay. I knew you were leaving the 13th,
Yeah.
or you'd be gone the 13th, so
Mhm.
we'd be back by the 19th?
No,
No.
not until the following week.
Okay, so you wouldn't be here on the 19th.
Me too.
So I wouldn't have to necessarily be here, but
You too? Is that
I'll
what you,
be out, yeah, I'll be traveling.
you be gone? All right, let's see.
what about that Wednesday,
I could do the
11.
the 11th?
I could do the 11th.
I could do the 11th.
Oh, Wednesday. Let's see. Yeah, I can do that.
Yeah, the 11th works for me.
4:30?
Yeah.
Could we make it 4 now that it's getting dark soon?
Yeah, I like that.
I
don't like to be out in the dark.
Somebody in the parking lot who's been circling ever since I've been at this meeting.
I have to work that day till, I think, till 4.
Oh, that's right, okay. 4:30.
All right,
Right, so what date are we?
the
Agree.
11th,
11.
4:30.
Are you here, Lord?
Yes.
I'm here.
Okay. I'll hear a motion for adjournment.
Move so to adjourn.
Second.
All those in favor, please say aye.
Aye.
Opposed? We are adjourned. And the game's already started.